So it is 7 o'clock today. I think we should start because we have a lot to cover. We're delighted to have Dr. Craig Shimazaki here with us today from Oklahoma in the US. Hello, Craig.
Hello.
Hi, thank you. I'm sure you'll be familiar with Dr. Shimasaki from past webinars of ours. He's going to be speaking today about long COVID, a post-infectious autoimmune syndrome. Dr. Shimasaki is a co-founder and CEO of Molecular Labs, a neuroimmunology precision medicine company focusing on diagnosing neurological, psychiatric, and behavioral disorders that are triggered by an autoimmune response. He received his BS in biochemistry from the University of California, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University Kellogg School of Business. He's an adjunct professor and senior entrepreneur in residence at the University of Oklahoma and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. So we'll have Craig giving his presentation for about 45 minutes. And during that time, please do put your questions in the chat box or the Q&A at the bottom. And then we'll have at least 15 minutes for him to answer them at the end. So we will be making the recording and the presentation available afterwards. There is an awful lot of, well, a huge amount of information in it. So don't worry if he goes over some slides quite quickly because you'll have it to look at again afterwards. Thank you very, very much, Craig.
Thank you, Jillian. I'm happy to be here, and let me work to get the slides here put up so you can see them. It's a pleasure to be able to talk to you all. So what I'd like to share with you is what is at least currently known or understood about long COVID today. This area of medicine and research is rapidly changing, and there's a lot that we know, but there's a lot that we don't know. So I want to talk about some commonalities and biological clues about other post-infectious autoimmune syndromes, and then share with you how not only this particular syndrome, but many other syndromes like it have opportunities to identify ways to have improved diagnoses and also better treatments and therapies. So before I start, I just want to disclose I am the president and CEO of Molecular Labs, and it's the company that we perform the Cunningham panel, which I'll briefly share the research about. And then the presentation is based upon published clinical literature and research literature. But as you might know, it is rapidly evolving. And so many of these things may change and even probably within the next few days or even weeks. So again, let me move over here. There are 5 topics that we want to discuss today. What is long COVID? What's the difference from a typical COVID infection? And then talk briefly about 3 other post-COVID syndromes. Then we'll look at briefly just a review of the SARS-CoV-2 infectious cycle and a little bit about how the receptor and those play a role in the autoimmune syndrome. And then talk about the biological mechanism that's based really on other infection-triggered autoimmune disorders that target both the brain and the heart. And then briefly share with you some research and some published studies on specific anti-neuronal antibodies that are directed against the brain, which we measure in the Cunningham panel, and how those are correlated with symptoms of autoimmune encephalopathy. So latest data, and this is constantly changing, as of April 5th, what we do know is that global cases of COVID-19 are over 131 million. Global deaths are about 2.8 million. And then in the UK, 4.3 million cases, and that's approximately 6.6% of the population. And then UK deaths about 127,000. In the US, we have actually over 30 million cases, which is about 9.4% of the population, and about 555,000 deaths. And as we all know that the virus not only is rapidly spreading and has, but that there are variants too that may play a role in the future of how this pandemic is actually curtailed. So one thing just to remind you a little bit about nomenclature, COVID-19 is in reference to the disease that's manifested in individuals. And February 11th, the WHO announced the name, hence CO for corona, VI for virus, D for disease, and 19 for the novel coronavirus that occurred in 2019. Whereas SARS-CoV-2 is in reference to the virus itself that causes COVID-19. And on that same day, the International Committee of Taxonomy named the new virus, S for severe acute respiratory syndrome coronavirus 2. We also know that there are two other coronavirus pandemics that occurred. The SARS-CoV, which was the first coronavirus that was identified in 2003 that started in Asia. About 8,000 patients had become infected, and the fatality rate was 9.6%. Whereas the MERS coronavirus, or the Middle Eastern coronavirus, in 2012 infected less individuals, about 2,500, but the fatality rate was much higher, almost 35%. Whereas what we see with the SARS-CoV-2, 131 million individuals, many more individuals are infected with it, but about a 2.2% overall fatality rate. So this brings to the definition, what is long COVID? And then what's the difference from what we think of as a typical COVID infection, if there really is one? So there's a number of evolving definitions, but one of them describes individuals who have experienced these persistent symptoms and or delayed long-term complications of the virus beyond 4 weeks from the onset of their symptoms. Another definition is that individuals continue to experience the COVID-19 symptoms after initially contracting the virus and after what would be considered the typical convalescent period, again, somewhere between 2 to 4 weeks. So there are some characteristics that were discussed in a BMJ webinar on long COVID and how to manage it. Some of the comments were things like a very common feature is the relapsing remitting nature of the illness, where you feel like you've recovered, but it hits you back. Profound fatigue was also a common symptom in most people. And then other symptoms included cough, breathlessness, muscle and body aches, and many more, which we'll briefly discuss about. One other comment was about twice as common in women as in men, and that the average age of long COVID was about 4 years older than people who had what might be termed as short COVID. And another comment was we were all focusing on the lungs and respiratory symptoms to begin with, but the virus attacks the same receptor that is in the heart too, and not just the lungs. We'll talk a little bit more about that receptor and where they're located. And then finally, another comment was it's a constant cycle of disappointment, not just to you, but the people around you who really want you to recover. The other challenge right now is that there's a lot of terms that are being used for long COVID. We'll stick with the term long COVID today, but there's the term long haul COVID, or the people who have it are called long haulers, long tail COVID, post-acute sequelae of SARS-CoV-2 infection, or PASC, post-acute COVID, chronic COVID syndrome, or CCS. So all of these will be referring to the same thing, but we'll use the term long COVID in this talk. So the National Institutes of Health and Care Excellence have identified 3 categories for COVID-19. The first category is acute COVID infection, and they've described that as signs and symptoms of COVID-19 for up to 4 weeks. The second category is ongoing symptomatic COVID-19, which they do include as long COVID, signs and symptoms of COVID-19 from 4 to 12 weeks. And then post-COVID-19 syndrome, also they categorize as long COVID, which includes signs and symptoms that develop during or after an infection consistent with COVID-19 that continue for more than 12 weeks and are not explained by another diagnosis. So in those two categories, they've identified that it's approximately 20% or 1 in 5 patients. So this appears to be more of a time-dependent categorization, because normally, and we say normally, an acute COVID infection is something described as up to 4 weeks of symptoms after an infection. So what is the typical acute infection look like? In the beginning, in February, March, CDC, many other organizations put out various types of symptoms to focus on: cough or sore throat, fever or chills, the shortness of breath, difficulty breathing, muscle aches, fatigue, headache, vomiting. And then they began adding the loss of taste or smell as other symptoms began showing up. But usually these were mild symptoms and they resolve within 1 to 3 weeks from onset. And this represents about 80% of the cases of individuals who end up with a SARS-CoV-2 infection. There's also an interesting study that was published in Nature Medicine of over 2 million individuals that were chronicling the symptoms of patients with COVID-19. And that particular study, which is still ongoing, lists, as you can see here, for both the UK and the United States, those that actually were tested positive and those that were not. Some were actually just not tested, but you can see in this situation over here, and I'm going to put up my little laser pointer, is the loss of taste and smell, fatigue, shortness of breath, fever, persistent cough, delirium, etc. So from here on, we're going to talk about long COVID, or this post-acute or post-COVID syndrome, but it's after the acute infection. Another study published in Nature Medicine showed that the timeline of this, in this case, where positive PCR in a nasopharyngeal swab was absent after 3 weeks, or around 4 weeks here, that they could not identify replication competent SARS-CoV-2 after 3 weeks. But yet the patients still experienced this post-COVID syndrome, chronic different symptoms that we described, including fatigue, etc. And this persisted with a negative pharyngeal swab, or a PCR swab. Now, we'll talk a little bit more about the infectious cycle and about how the virus itself may be resident in other areas of the body, but definitely there are receptors that are there for the virus in these other parts of the body. Another study that was published here as long haulers in this survey report that identified by Survivor Corps. As you can see, there was 1,567 individuals who were called long haulers, and they described nearly 100 different symptoms. And so 100% of them had fatigue, and usually it's very severe fatigue, muscle, body ache, shortness of breath, difficulty concentrating or focusing. We'll talk a little bit more about that in the brain fog. Inability to exercise, headache, difficult sleeping, anxiety, memory problems, dizziness, and the list goes on. But many of these symptoms overlap with those of patients with myalgic encephalomyelitis. In another study that was published, they identified 50 long-term symptoms in a systematic review of these patients. And you can see the list here goes on. Again, the 5 most common symptoms were fatigue, headache, attention disorder, hair loss, and dyspnea, or shortness of breath. The CDC also reported long-term effects of COVID-19 on their website. And you can see the normal symptoms that you would see with acute COVID, and then other long-term symptoms, included those that were mentioned, but they described that this affected many different body organ systems, such as cardiovascular, respiratory, renal system, dermatologic, and neurological, which we'll focus on a little bit more, and psychiatric. In fact, this study that just came out in the Lancet yesterday, Lancet Psychiatry, followed after 6 months the infections of patients who were infected, but post 6 months, of over 136,000 survivors. And what they found was that 1 in 3 COVID patients were diagnosed with some form of neuropsychiatric condition 6 months after an infection. So it's clear that there is parts of this syndrome that impact neurologic, psychiatric, brain, nervous system, etc. So in summary on these organ systems, you can see that a whole host of organ systems are involved, from the lungs, cardiovascular system, the skin, kidney, the liver, the brain, and the gut and the eyes. We won't go into treatment, and that will be covered in another talk or other talks, but here's a couple of references that you may want to look up. One by the World Health Organization on the clinical management. The BMJ has one on management of post-acute COVID and primary care. And then the European Society of Cardiology has guidance for the diagnosis and management of cardiovascular disease during the pandemic. As was mentioned, many of these patients with long COVID experience vascular and cardiac issues. So in summary, a little bit about some of this is that long COVID appears to be a multi-organ system disease with a broad spectrum of manifestation that obviously affect many organs, including the lungs, and that survivors of other coronavirus infections, such as the SARS epidemic in 2013 and the MERS in 2012, there was also describing very similar types of persistent symptoms. So this is not unique or new to the SARS-CoV-2. It's just that more patients have been infected, and as a result, more individuals have been identified with this long COVID. It seems to involve cellular damage, the innate immune system response that seems to go awry, with many types of inflammatory cytokines being produced, and they mention a procoagulant state. And of course, the definition is evolving, and the criteria might be different in the US versus the UK. As you can see, the multiple terms used for long COVID, but right now it appears to be defined more so by the length of the condition or the disorder or the syndrome. One other study that the New York Mount Sinai Health concluded, they identified that the median age of 42 of patients with long COVID, and that they didn't require hospitalization when they had COVID. And they seemed to have less severe cases. They were much younger. They were previously fit and healthy, and they exhibited an extreme response after the initial symptoms have gone. So what are some of the other syndromes that are involved? And there are 3 that are showing up. One of them in children, called multisystem inflammatory syndrome, POTS, or postural orthostatic tachycardia syndrome, which has been around, and myalgic encephalomyelitis, which has also been around, but it is tied to many individuals with post-COVID syndrome. So looking at MISC, there's a very similar association or correlation with the symptoms of Kawasaki disease. The CDC defines MISC as someone who's 21 years, less than 21 years old, and has a fever, has lab evidence of inflammation, which is involving the immune system, something that requires hospitalization and have more than two organs involved, and no other reason for the disease, and a positive COVID or a recently positive COVID test. But if you look at Kawasaki disease, infectious disease specialists have identified it really as an infection with a classic immune response, and others have identified it as an autoreactive hypothesis with a pattern called molecular mimicry, which we'll talk about briefly too, that results in an immune response that's directed against that tissue. As far as POTS is concerned, some of you may be familiar with it. It's a condition that affects blood flow, and its symptoms you can see here described, but they occur when a person stands from a reclining position, and it's relieved when they're sitting or lying back down. But basically, it's a dysautonomia, where the dysfunction of the autonomic nervous system, which controls and affects circulation. But interestingly, when it's associated with SARS-CoV-2, or in the past for POTS that has occurred even in patients after streptococcal infections and other infections, usually developed after a viral illness or other types of infection. So as far as ME, you can see the symptoms here from ME: fatigue, malaise, memory. Many refer to these as brain fog. And studies have shown that this is not new as far as post-viral infection, because in the first SARS virus, one study showed that 30% of those survivors actually developed similar symptoms. So we're not really looking at anything that's new, and it's quite possible that all of these syndromes may be just clinical classifications of subsets of these patients, but the mechanism may be very similar. So let's turn our attention to a little bit about the SARS-CoV-2 infectious cycle. And you may have seen many of these different illustrations where the virus itself, the spike protein in particular, identifies and binds to the ACE2 receptor, or the angiotensin converting enzyme 2, and then a protease will cleave this and allow it to fuse with the membrane, and the virus then goes through its normal replication cycle, where the body actually will then the cell will make more copies, and it'll egress. And again, as long as it can find an ACE2 receptor, the virus itself can bind and fuse and infect these cells. So if we look at a little bit more detail in as far as the virus is concerned, the spike protein is a key protein that's involved with the recognition of the human receptor, and hence, which is why we know and see that these vaccines are made accordingly, specifically with the spike protein in mind, so that the antibodies that are developed can actually recognize and block that. Well, what's the normal function of the angiotensin converting enzyme receptor? Well, in this illustration, what you can see is the ACE2 receptor on cells, and it's the one that the SARS-CoV-1 and SARS-CoV-2 bind to. But its normal function is that it regulates blood pressure, wound healing, and inflammation. By modifying this angiotensin 2 to other forms, and in doing that, this particular molecule will increase blood pressure and inflammation, damage to the blood vessels and tissue industry, whereas this version actually is involved in anti-inflammatory work, anti-proliferative work, anti-fibrotic work, and a whole host of others involved in the renin-angiotensin system. But the interesting thing is the ACE2 is found in and expressed in cells in the eyes, the heart, the kidney, the gut, the liver, the lungs, blood vessels, upper airways, and central nervous system. And what you may notice is these are almost identical to the symptoms or the organ systems that were previously described. Now, whether or not this is actually a viral infection of these organ systems or an immune response that is representing a molecular mimicry towards these different parts of the body is not completely clear yet, but we do have some research that favors at least a bit about the molecular mimicry and the targeting of these autoantibodies. So that takes us to what are some possible biologic mechanisms based on these other infection-triggered autoimmune disorders that target the heart. You know, the idea that history often repeats itself. We can find these things often in medicine, and they're not necessarily things that are new, that we think are new. For instance, the immune response against self-tissue. In fact, there's been postulations that long COVID may be caused by friendly fire and that rogue autoantibodies could be driving the severe COVID-19. And we think of friendly fire as in the wartime when our most strongest military forces can't distinguish between the good forces and the enemy forces, and then begins attacking itself. So autoantibodies may actually cause the medical condition in long COVID, and the virus itself may trigger autoantibodies that recognize other parts of other organs. And there is publications and previous publications earlier on that identified multiple neuropsychiatric manifestations in patients with the coronavirus or SARS-CoV-2 infections. But how does molecular mimicry, or what we call friendly fire, occur? So this is really the reasons that the vaccines are effective, is because what's presented to the body is a part of the organism that actually will trigger an immune response. And we call those epitopes. So they're parts of molecules that the body can recognize and make antibodies to, but not necessarily give the organism, the full organism, so that it can cause the disease. Hence, the vaccines are made from multi surrounded around the spike protein or the RNA for the spike protein. And then the immune system actually kicks into gear through a whole host and cascade of different types of things in which antibodies are finally produced. Well, in some people, let's say that epitope that the antibody is made towards is identical to a part of a brain neuron, or a part of maybe the kidney, or a part of the liver. And this does occur because if you think about the protein alphabet, there's only 20 letters in the protein alphabet. At some point, there will be a sequence that are identical in other organisms and organs that are identical, but our immune system suppresses those particular antibodies. But in some individuals, they are actually made and escape, and they actually do continue to produce antibodies through their B cells and the plasma cells. And when that happens, the antibodies then begin to attack in a friendly fire manner what they think, or not really thinking, but they recognize this part of the epitope that is a part of the body, and hence we get many of what we call these autoimmune diseases. But in this case, it may not be really a disease per se, but a dysfunction of the immune system that is triggered by an infection. Hence the term molecular mimicry. So there are instances, and medical journals are acknowledging the connection between infections and neuropsychiatric disorders. In fact, in 2019, JAMA Psychiatry, before the COVID epidemic, published a study of over 1 million patients that were followed from birth to age 18. And this epidemiologic study showed that if a patient was hospitalized for a severe infection, they were at 80% more increased likelihood of developing or being diagnosed with schizophrenia, autism, OCD, ADD, personality, and behavioral disorders. And what they concluded was the study provides compelling epidemiologic evidence that severe infections are linked to the onset of neuropsychiatric illnesses, in this case in children. So an accompanying editorial identified a question and says, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? Circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in pandas and other mental disorders. So if you're not familiar with pandas, I'll just briefly describe it because it may be a medical model for what we're seeing with long COVID, but many other types of autoimmune or neuropsychiatric disorders that are triggered by an infection. So PANDAS is an acronym for Pediatric Autoimmune Neuropsychiatric Disorder associated with a streptococcal infection, not the bear, but it is interesting. It's actually named in that manner. In the 1990s, Dr. Susan Swedo at the National Institutes of Mental Health had identified a large group of really over 50 children who had sudden onset of obsessive compulsive disorder and many other symptoms and behavioral changes after a strep infection. So that was published back in 1998. And it's also was known, and they had patients who had post-influenza infections, post other infections, and the list can go on, but it is an infection-triggered autoimmune condition. And so what does that mechanism look like? Well, as we mentioned, we all get microbial, viral, or fungal infections, and mentioned that our body is very good at producing and recognizing these agents as foreign, but then making antibodies against them so as to protect us. Well, in certain patients, certain individuals, the particular antibodies that are made actually are those that cross-react with a part of that organism that's common to, let's say, a neurologic receptor in a condition or a phrase we call molecular mimicry. So in this case, what happens is as they cross the blood-brain barrier, they interrupt normal brain function, and you can see the manifestations of these neuropsychiatric symptoms, including anxiety, aggression, rage, OCD, tics, etc. So again, as I mentioned, if we look at history, neuropsychiatric symptoms triggered by infections is not novel or new. Back in the 1800s, Sir William Osler described these bizarre and precipitative behaviors in children and called it chorea minor. It was this obsessive compulsive disorder and the symptoms that occurred in patients and were diagnosed with Sydenham chorea, which is this choreiform movements of the hand. It was also called St. Vitus's dance, where the movements of these individuals were uncontrolled, but they looked like a dance movement. It was also shown and noted that Sydenham chorea was the neurologic manifestation of rheumatic fever. So triggered by a strep infection, antibodies attacking the heart and attacking the brain cross the blood-brain barrier and interfere with normal neurologic function. So we're doing research, but we also have a panel that identifies different targeted autoantibodies. But our research on other infection-triggered autoimmune sequelae through molecular mimicry, we know and see that in the case of pandas and PANS, Sydenham chorea, and what we might call basal ganglia encephalitis, and even neurologic Lyme, that the presence of these autoantibodies are contributing to these symptoms, and when they're gone, these symptoms abate. Based on our research also, we have seen that antibodies can be directed against parts of the heart and even like rheumatic fever, the heart valve itself. In myocarditis, cardiomyopathy, heart failure, and atrial fibrillation, we see that there are antibodies directed against various proteins in the heart. The question is this also the same thing that's happening in long COVID, where patients with very similar symptoms, neurologic, psychiatric, cardiovascular, occurring as a result of molecular mimicry? We're in the process of identifying these patients and antibodies in these patients, rather, and looking at the presence of them and which organs they may be targeting, and seeing if there is a direct correlation with that in the presence and absence of these symptoms. So that leads me to the last part here that I want to share. We have published information showing that specific anti-neuronal antibodies and their ability to stimulate brain cells in patients with infection-triggered autoimmune encephalopathies actually correlate with the presence and absence of these types of symptoms. So the panel that we provide and that AONM is responsible for there, and if you have any interest later to talk with them about specifics, they can set some time up to do that. But just briefly, these antibodies we examine are those directed against the dopamine D1, the D2 receptors, the lysoganglia tubulin, which is a intracellular protein that's highly concentrated in the brain, and this CAM kinase activity, which is an activity that stimulates the upregulation and the synthesis of the neurotransmitters dopamine, epinephrine, and norepinephrine. So the panel of these, if antibodies are present against any of these, we can identify them. And some of the clinical data, over 10,000 patients that we've tested, we find that when they have antibodies against the dopamine D1 or the D2 receptor, that in the case of the D1 receptor, it's been associated with things like mood dysregulation, poor concentration, OCD, and sensory or motor abnormalities. When they have antibodies directed against the dopamine D2 receptor, we see more of the movement disorders like in sydenham chorea, the choreiform movements, hyperactivity, sleep disturbances. And then when they're directed against the lysoganglia side, which is actually contained within the myelin sheath of nerve cells, we see that they can exhibit motor and vocal tics, experience different kinds of connective tissue pain, again, sleep disturbances and OCD. When they're directed against the tubulin, we find that the presence of this brain fog or this inattentiveness, this sort of struggle with concentration is heavily present. Additional things such as sensory or motor abnormalities and emotional ability, aggressive and or rage behaviors tend to be present in these patients. And then when the antibodies are present that stimulate this particular enzyme called the CAM kinase 2, and we do this through an assay where we incubate these antibodies or the serum on these human brain cells and regulate and watch for the upregulation of this activity, that when they're elevated, we also see that patients generally have an active infection, or in many cases, multiple infections, but they're triggering these antibodies to stimulate the CAM kinase. So we see this kind of fight or flight, autonomic nervous system activation, separation anxiety, things like bedwetting, sensory sensitivities, and also involuntary movements, fight or flight behavior, as I mentioned. So I want to share with you just briefly one study that's published in 2020 on February 15th in the Journal of Neuroimmunology, which is looking at patients had 2 or more Cunningham panels before and after treatment. And so we were looking whether or not the presence of these types of antibodies correlated with the presence or absence of these symptoms. In the study, there was 58 patients, and they were equally divided in the sense where the symptoms that they had were very common. You can see the difficulty concentrating, OCD, emotional ability, anxiety, sleep disorders, etc. And group 1 was the patients who actually got well after treatment, and group 2 were patients who did not get well after treatment. So symptoms were very similar, and this had to do more with, we believe, the treatment. But what we wanted to do was look at whether they correlated with the presence or absence of these antibodies. The other factor that was universal among all of these patients is that they had multiple co-infections. Most of them had strep, but many of them had 2 or 3 or even 4 infections of maybe Lyme, ehrlichiosis, Epstein-Barr, herpes virus 6 or 1, Bartonella, parainfluenza, herpes zoster, streptococcus, staphylococcus, candida, mycoplasma. And it makes sense that a patient with an immune dysfunction, once they're infected and maybe the immune system is dysregulated, that you would see or could see more infections in the cases where those patients actually are having difficulty fighting off these infections. And that happens to be the case. So we look at group 1, the patients who either improved or completely resolved, and look at this heat map for their test. So they were positive for either 1 or more of these autoantibodies against these targets that I mentioned, or stimulating the CAM kinase enzyme. And as you can see, that every one of them had 1 or more. Post-treatment in this group, either improved or completely resolved, you can see a dramatic change in the presence of these autoantibodies that are attacking the brain. And you can see the difference in the number of positive tests. In the interest of time, I won't show, but the exact opposite occurred with group 2, patients who got worse. In fact, their number of tests increased. So we looked at what was the sensitivity and specificity of the correlation with symptoms, an accuracy of about 86%. We're working on a logistic algorithm to actually take portions of this and actually identify the contribution of each test towards that. And we can actually see an increase in accuracy up to 90%. The good news is that patients, and we have thousands of these patients, when they're properly diagnosed and treated, they get well. This is Adam, who was diagnosed with ADD, and they were considering institutionalizing him. They found out about the idea of these autoantibodies. We tested him, he was positive, and he received proper treatment, is completely well. Just a couple months, she sent me a picture of him running cross country at school, saying recovery is possible. He is 10,000 times better. So there is a pressing need to create multidisciplinary interactive medical teams to address long COVID. And I understand that that's actually beginning to occur there in the UK, because in the current state of medicine in general, there is a separation of these into organ systems, and they're studied often independently. But in order to address the long COVID and many complex disorders, we really need to have these overacting and interacting and multidisciplinary teams that involve psychiatry, neurology, infectious disease, immunology, and cardiology. So in conclusion, I want to ask the question, is this really just the tip of an iceberg? Because we've had so many people that have been infected with SARS-CoV-2, we have a very large number of long COVID patients, but MIS-C, ME, POTS, PANDAS, PANS, ADD, ADHD, epilepsy, schizophrenia, ASD, and many more, it could potentially be, and we believe and have seen this, infection-trigger autoimmune disorders, or portions of them could be, because these are generally diagnosed by symptoms and not by etiology. So I know I've covered a lot here, and I wanted to be able to at least give you a background, but our mission here is to help change how medicine is practiced for infection-triggered autoimmune and neuropsychiatric disorders. And I know many of you are clinicians, and that you're on the front line. They're taking care of these patients, including those with COVID and long COVID. And we thank you and support you, and would want to do anything we can on the research and the clinical side for testing. And eventually, we're working to find and identify treatment targets to help those with these disorders have hope and get well. And so that concludes my presentation, and I'd be happy to answer any questions if anybody has any.
Thank you very, very much indeed, Craig. That was really stunning. Lots and lots of new information in that. I'm sure very new to most of us. So I will start going through the questions that have been received. So first of all, one of them is whether you're actually suggesting that long COVID and ME, or chronic fatigue syndrome, are synonymous. What's your feeling there? I mean, obviously it's early days yet, but do you think there are great overlaps there?
Yes, that's a complex answer or question, but an answer probably is not yes or no, but believe that these constellation of symptoms that would put a patient to be diagnosed as ME could quite possibly be the same set of symptoms that are found in long COVID. Now, it doesn't mean that all ME patients are long COVID, because as you saw, many of different infections could potentially even trigger that, like Epstein-Barr, herpes virus 6, other types of viral infections. But the mechanism is likely, and we believe for those patients, could be either identical or very similar. And therefore, the treatments could also be effective that are very similar.
Thank you. Would you suggest some autoantibodies in patients with chronic Lyme and seizures? Would you be able to actually identify some autoantibodies, or would you say it's just all of them that are in the panel?
In the panel, yes. In fact, from our clinical work, what we do is we receive the diagnosis of these patients, and often they will have these clinical diagnoses of seizure disorder, epilepsy, but they will have the presence of these autoantibodies, and they will respond to the same anti-infectives and immune modulators. So what we see is that many of these different disorders can also be triggered by these autoantibodies. In fact, it's known that we look at epilepsy, which occurs in about 1% of the population, that 50% of it is known to be autoimmune because they don't respond to this typical anti-epileptic medications. So I think the take-home message is that when we diagnose and categorize something from symptoms, it doesn't have anything to do with the etiology. And so in order to treat it effectively, we have to understand what the etiology is, not what the cluster of symptoms are, because the cause could be very different from one for the other.
Yeah, thank you. I think you've probably answered the next question then already, which I'll just ask it anyway. Do you think it's important to give a specific diagnosis, e.g. POTS or ME, or is it good enough to treat everyone as having long COVID?
No, that's a great question. And again, long COVID is again a constellation of symptoms. I think the most important thing is to find out what the etiology is. Meaning, is it an infection triggered autoimmune condition that happens to be attacking certain parts of the body, or is it not, or is it genetic, or is it something else? And once you identify the etiology, and in this case, we do use the panel to try to identify, do they have at least any of these 5 targets present? If it does, if it's positive, then we generally will find they will respond to anti-infectives, immune modulators, anti-inflammatories, regardless of the quote unquote diagnosis. Now, it doesn't mean that they can't have comorbid conditions, which they could have, maybe some form of a genetic condition with an infection-triggered autoimmune condition on top of it. So what we see is that they will return to baseline once that infection-triggered autoimmune condition is addressed.
Far better than being on psychiatric medications for life, which is where the investigations of this began in the late 80s, as you described. One technical question that might be difficult to answer here right now, but can you confirm whether the COVID-19 fatality rate of 2.2% is the infection fatality rate or the case fatality rate?
Yeah, I did that one. I couldn't answer there. I did the math, but I think it could be both. And certainly there's a lot of unreported cases. And then we all know that there could be maybe comorbidities. So I think the general takeaway is that rather than the exact percentage, that it is a small percentage, but it's a big number of people. And that compared to maybe the MERS virus, which had about 35% fatality rate, we're dealing with something that does have a lower fatality rate, but it is highly contagious and infectious. And so I think that may be more important than the actual percentage, although it may describe a little bit about the effectiveness of the treatment regimen and things like that.
Okay, thank you. Dr. Klinghardt and other therapists have sensitized us to the idea of retroviruses underlying some types of chronic disease. And when one does begin looking up EBV and CMV and so on in Google Scholar or whatever, one often sees that they can actually trigger retroviruses, that this is a well-known phenomenon. And one question has come in, could SARS-CoV-2 or COVID allow a retrovirus to cause ongoing issues? Is this known yet or not?
In maybe new infections of retroviruses or just co-infections? Yeah, I think we've seen that once a patient might be in a immune dysfunctional state, that it's an opportune infection. Opportunity infections can actually infect these patients, and because their immune system is not as robust. And so that quite possibly could be the case. If you take maybe a bit of a more extreme example like HIV, those patients which the HIV virus is targeting the CD4 cells or the immune system, you see multiple just general infections that wouldn't hurt normal immune functioning individuals, but they will have multiple infections, including fungal infections, things like that. So it is quite possible that that sort of same concept, when the immune system is dysregulated, that it may provide an opportunity for other types of infections like that to actually gain hold in a person's immune system.
Thank you. You told us about the boy at the end who got 10,000 times better. There are obviously questions about what kinds of treatment he received that made the difference. Is that anything you know about?
Yes, and we do follow that, and we're working on actually a treatment algorithm to tie into the panel results, which we're hoping to be able to do here in the next short term. But that particular patient actually did receive, and I remember this correctly, some form of immune modulators. I believe it was intravenous immunoglobulin, and then also in some anti-infectives. So the patient had a number of infections. They were treated with intravenous immunoglobulin for the immune system dysfunction, and then also some anti-inflammatories. And if you think about the immune system, once you get rid of the stimulant, which in this case is the infection, and you treat the aberrant immune system, then the patient actually, in many of these cases, in this case, went back to what she considered his normal behavior.
Thank you. There are quite a few questions about treatments, and I know that that's not normally an area that you go into so much because your specialty is the testing, but that's fascinating that you've just mentioned the treatment algorithm. So maybe for those who are asking about treatments here, we could say that you'll come back again whenever that's ready. And you did say short term, and then tell us a bit more about that. Obviously, there are differences between treatments available in the States, like the IVIG that you've just mentioned, and treatments available here. But I'm thinking perhaps we could have a doctor or therapist from here as well, together with you, and then talk about the different options. That would be fascinating, wouldn't it? So
yeah, that would be great.
Bear with us, those who've asked about treatments, and we will come back to you on that.
And Julian, I might make one comment that the treatments tend to fall into different 3 or 4 different categories that are effective, whether they be allopathic or naturopathic. One of them is anti-infectives, because that, whether they be naturopathic, allopathic, or antibiotics or antifungals, you have to treat the infection. The second category is the inflammation. Because it's triggering an immune response, you treat the inflammation. Again, whether that's allopathic, naturopathic. And then the immune dysfunction. And often those things, in these cases where severe patients, tend to be things like the IVIG, plasmapheresis, rituximab. But we have seen many effective naturopathic components, because again, as long as they fall into the same categories, they tend to be very effective, as long as, of course, they're all treated. You can't just treat one part of it and expect the whole thing to get well. It's a complex disease. Therefore, you must treat all of the different components of the disorder.
Thank you. One question about nosebleeds here. Do you think that nosebleeds in long COVID / pandas, etc., could be a dysregulation of the histamine system?
Yeah, no, that's an interesting question. I don't know the answer to that. It certainly could, because we're talking about a virus that actually infects and has ACE2 receptors on the vascular system. We also know that fungal infections and fungal metabolites can trigger nosebleeds, and multiple from nosebleeds that cause the blood vessels around the nose to be easier to be broken. But it's quite possible, and it certainly could make sense when we're talking about a virus that has a receptor on multiple organs, including the vascular system.
Thank you. Could you possibly put into the chat or send through later the reference to your last paper?
Yes.
Thank you. Where do you place enteroviruses, which are so strongly associated with ME, in your scheme? That would be Coxsackie or echovirus, others.
Yeah, I'm not as familiar with those particular viruses. We know that the herpes virus 6, the HS, other types of herpes virus tend to be associated with those. And we do see that they do have presence of antibodies that are directed against the heart, which we believe contributes to the fatigue. And then the antibodies directed against the brain, which we believe are contributing to the brain fog. But I'm not as up on those other infections that certainly can be associated. Again, if it's a autoimmune infection triggered syndrome, then certainly other types of infections that have an epitope very similar to those would be likely, and certainly could, as you saw the very long list that I mentioned in the paper of all of these different infections.
Thank you. Another question here regarding gastrointestinal symptoms. Is it possible that this specific autoimmune component of long COVID could be involved with GI issues as well?
Absolutely. In fact, there are publications showing that in the absence of maybe a positive nasopharyngeal swab, that there can be identified the SARS-CoV-2 virus in stool. And again, if you remember that in the gastrointestinal system, the ACE2 receptor, or the ACE2 protein, is also present in the GI. So it certainly would make sense.
Thank you. And what is your sense as to why some children do develop these autoantibodies and others don't? Is there, is there some sort of rationale to that?
Right, that's the million-dollar question, but we do have some kinds of clues. There is the notion of some genetic susceptibility or predisposition, and it doesn't mean predisposition to long COVID or anything, but that a predisposition to some potential immune dysfunction. So we tend to see the presence of family history of some form of immune dysfunction that is correlating with that. Now, we could use the same analogy if you talk about lung cancer and smoking. So genetically, we would say if we didn't look at genetics, why would we know that about 98% of all lung cancers are smokers, but it doesn't explain why only 15% of people who smoke all their life get lung cancer. So if you look at that side of it, you would say, well, it's not really correlated. But in those patients, it's very likely that they have maybe a gene that doesn't control their cell cycle as well, doesn't metabolize carcinogens as well, doesn't stop cell replication. So the combination of these multiple, we call them single nucleotide polymorphisms, these genetic hits, that you get enough of them, and then you get these different types of diseases, or let's call them infections, that are severe enough that your immune system just goes a little awry. And so as you saw, 80% of the patients tended to have what maybe we'll say short COVID or an acute infection, but 20% of them have this, we'll call it an immune dysfunction or a dysregulation. And so it's kind of that short answer, but it's a bit more complicated because it involves both the adaptive and certainly the innate immune system, and its children tended to be less severe for whatever reasons. But it is a great question. I believe that will be elucidated over time.
Well, maybe the next time we have you on, we could investigate that in a bit more detail as further information has come in. I know it's already after 8 here in the UK, but just one further question, because it's so fascinating and you may be able to throw light on it, which is, what is the mechanism by which IVIG does actually work in these children and also adults who have upregulated autoantibodies of this kind?
Yeah, that's another fantastic question. We have our theories, and we certainly believe some of that is the case, but it could be multiple mechanisms. One of it that we see that in these patients, like pandas and pans, it's generally high dose, meaning the 2 grams per kilogram, or 1 to 1.5 to 2 grams per kilogram versus the low doses. And part of this could be a feedback mechanism, meaning the Fc receptors on all these antibodies are there, that in normal homeostasis in our body, it tells the body to stop making antibodies because we've got too much. And so one mechanism can be, and is likely a feedback mechanism, that tells the body to stop making all of these antibodies, whether it is because of the exogenous antibodies that are doing it. The second explanation is that there can be, and certainly can be, what we call anti-idiotype antibodies, meaning antibodies against certain antibodies that are present that downregulate that. And that's a normal function of the body, that when we make certain antibodies, there's also anti-idiotype antibodies. And then another one is just in general, that there may be other cofactors in it, and those cofactors that actually help regulate the immune system. So I tend to favor the feedback inhibition model, because we don't see that it works as effectively when you use low dose IVIG. So the response of the human body is homeostasis. It's trying to counteract something, and that's the normal mechanism. And so when you give large exogenous amounts of antibody, and the Fc receptor is the one that's common, that it tells the body to downregulate things.
Thank you very, very much indeed. Just to mention regarding treatment, that we did have Dr. Sam Yanuk, who I know you work with closely in the States, on just a few weeks ago. And he did talk about therapies, and in fact, a lot were natural therapies for long COVID. So we will also be having further talks on this topic, and we will be having you back again as well to talk about your treatment algorithm. Thank you for offering that. So that's fantastic. Very, very interesting information. Really fascinating, and we'll all be going over your slides again in great
Okay.
detail, I'm quite sure. Thank you.
Thank you for inviting me. I'm happy to share with your group, and I will post the paper, the reference to the paper there, and be happy to come back and share more with you as we learn more.
Thank you, super. Thank you everybody as well for being here, and we'll be in touch with you again about further webinars. Thanks a lot. And thank you, Dr. Shimasaki.
Bye-bye.
Bye-bye.